It's 9:55 on the dot. So let's go ahead and get started. We'll go with this session until 11:40, and I'll turn things over to Kelvin. Kelvin, can you hear me all right?
Yeah, sorry.
Great.
Okay. Let me read this. All right. Hey, everyone. I'm Kelvin. I am a primary care R2. And today I wanted to talk to everyone about medical and surgical weight loss, specifically for the primary care provider. So I have no disclosures. First, I'd like to give a shout out to the UW Medicine Center for Weight Loss and Metabolic Surgery. I work with Dr. Laura Montour to kind of help me with my slides. So for anyone who has patients interested in weight loss and you need a little bit more help, we do have the resources at UW to help them. So today, the four things I'd like to talk about are medications that are commonly associated with weight gain, the FDA-approved medications specifically for weight loss, bariatric surgery and whether or not it works, and then a few therapies that we don't recommend. So to start off, I have a question. A 48-year-old woman with diabetes and peripheral neuropathy on gabapentin comes in and asks if there's anything she can do to help lose weight. Aside from lifestyle modifications, what can you do right now to help her lose weight? Yeah, and these are your choices. You could add insulin. You could wean the gabapentin. You could switch gabapentin to lyrica, or you could refer to the weight loss clinic.
Give another 5 seconds or so.
Wow. I guess there's more than one right answer, but we'll kind of get to this, but the answer I thought was correct, most correct, was wean the gabapentin. So another question before we kind of get into things. A 32-year-old man comes in to establish care with you. He was just diagnosed with schizophrenia and started on risperidone. He's concerned about metabolic effects of antipsychotics. Which of the following antipsychotics is the least associated with weight gain? And everyone, or for the most part, people got it right. It's aripiprazole, Abilify. So there's a laundry list of medications associated with weight gain. And if you go to UpToDate, there's the list is endless, but I basically copied this list from there. And this is just something that I think people should be aware of when starting these medications, specifically, prednisone when people are started on long-term steroids, antipsychotics. Most of them really are not weight neutral, and then a lot of anti-epileptics are also not weight neutral. Pregabalin is not on this list, but it is actually associated with the same, if not more, weight gain as gabapentin. And so the next list I have is actually medications associated with weight loss. Oh, aripiprazole should be under the antipsychotics. I accidentally deleted that. There are only two antidepressants really associated with some weight loss: bupropion and desvenlafaxine, and then a couple of anticonvulsants, and then some stimulants. Are the psych-related meds associated with weight loss from a mood/change in habit etiology, or more from a metabolism change? So specifically the bupropion we'll get to, but bupropion naltrexone is an FDA-approved weight loss medication, and it's more from the metabolism change. Desvenlafaxine, I'm not really sure. But for the most part, I wouldn't think of antidepressants as a medication that you should use for weight loss. That will cause weight gain. Oh. Let's see. The ones that cause weight gain. I'm not sure, actually. I can get back to you on that. Okay. So before we get into FDA-approved medications, I have another question. 52-year-old man's been taking phentermine for the past 2 years and it's helped him maintain a 20-pound weight loss. He comes into clinic and says, I'm worried about the risk of long-term use. Which of the following is true? If he continues to take the medication, he's at higher risk of developing CAD than had he not taken it. If he stops taking it, he will suffer amphetamine-like withdrawal. If he stops taking it, he's likely to regain the weight he lost. If he stops taking it, he will likely have cravings for it.
Give another 10 seconds or so. I know this is a longer answer choices.
All right. So the one that is most supported by evidence is if he stops taking it, he's likely to regain the weight he lost. The other three we'll get into later. So the FDA-approved medications for weight loss, all of the trials were done in combination with diet and exercise, but they are phentermine, a combination of phentermine and topiramate, combination of bupropion and naltrexone, Liriglutide, and Orlastat. There was another one, but it got recalled due to increased risk of cancer and death. So if you see anyone on orcasterin, take them off. So who exactly qualifies for weight loss medications? Let me see this question. I think it's still an area of pretty active research. Thank you, Mary. Patients with a BMI greater than 27 and obesity-related comorbidities, including type 2 diabetes, osteoarthritis, sleep apnea, gallbladder disease, and there are more that you can look up, or patients with a BMI greater than 30 with or without any other comorbidities. So I'd like to go through all the medications and kind of like how they work, but also some of the data behind them as well. So phentermine stimulates the sympathetic nervous system. This is the dose you use. And to keep things short, I'm going to combine it with phentermine topiramate. Topiramate is thought to potentiate the effects of the phentermine. And this is the dose. You would start low and titrate up to effect. And so going through the data, like, does it cause weight loss? And yes, it does. It causes, like, at the dose that we typically do, probably around 10% weight loss. And as you can see, over 70% of the patients had at least 5% weight loss. And then over half of the patients had greater than 10% weight loss at the therapeutic dosing. So then we go to the safety concerns of phentermine and topiramate. This is something that's been I've heard a lot of patients ask about the safety profile of it. And kind of going back to this question, the three most common things I've heard are, what about developing heart disease? Isn't this a stimulant? What about amphetamine-like withdrawal? And am I going to crave this medication? So there was a study done where it was an interesting study design where they took patients who had been using it for 1 to 2 weeks, and then people who had been using it for over a year. And in order to figure out if they had cravings, what they did is they did a survey, and they said, okay, so how much are you craving the phentermine topiramate? And the people who had been on it for a year craved the medication less than the people who had been on it for 1 to 2 weeks. And the theory that they had was that people, if there's a physiologic craving that would be formed, it would be formed from long-term use and not acute use. So that's kind of where they got this data to support that it does not actually really induce cravings. And so they asked, okay, what about dependence on the medication? So there's this SDS, I forgot what it stands for, but something dependency scale. And what they did is they used the same two groups, the acute group, 1 to 2 weeks, and the long-term group over a year. And they gave them the severe dependency scale questionnaire. And for people who had cocaine use disorder, the score was typically greater than 3, so 4 or 5. And then for amphetamine use disorder, is typically greater than 4. So when you look at the data, you can see in the 1-year group, only 2 people had a score of 4 or 5. And when you look at that compared to how many people were in the study, they thought it was insignificant. And then in terms of withdrawal, if you look at the data that they have, is the one significant difference was in hyperphagia. And so once you stop taking the medication, you got really hungry. And you'll see like the total score, there was a significant difference. And so they went down, and what was significant was the reverse vegetative syndrome score, and it was only hyperphagia within that score. So then there was a question about cardiovascular health, and there were a lot of long, complicated charts. But basically what they did is they looked at people who were currently using phentermine topiramate and people who had previously used it and were no longer using it. And they looked at adverse coronary events. And I'm not going to go through that data because it's not that important, but people who were currently using the medication actually had slightly fewer cardiovascular events than people who had previously used it, but there's not a lot of data. What we do know is that it does not significantly increase the risk of CAD. The next medication that's pretty effective and is FDA approved is bupropion naltrexone. So bupropion stimulates fullness. Another question earlier. Combo drugs are expensive. You can prescribe the drugs individually with dosing. Thanks, Aseeb. Yeah, you can prescribe the drug separately as well. So bupropion stimulates fullness, and then naltrexone has the same effect through a different mechanism. And it also works anywhere from 7 to 12%, and studies showed a yearly weight loss of around 8% when in combination with lifestyle and calorie reduction. And so I thought this was one of the only drugs that had a study about number needed to treat, and I thought it was really interesting to get to at least a 5% body weight loss. You really only needed like 2 to 5 patients, and at the max dose, it was only 6 patients. So this is a pretty effective medication. The safety considerations here are nausea, dizziness, and headaches. Basically, all of these medications cause nausea, so just keep that in mind. And so the next medication, Liriglutide, which is a GLP-1 agonist that is both approved for type 2 diabetes and for weight loss, even with people who don't have diabetes. So it works by stimulating the vagus nerve, which signals satiety to the brain and also slows gut motility. Specific populations to consider are people with type 2 diabetes as well as NASH. You start low, and then the target dose is 3 milligrams because that's what all of the trials showed. Is it just lyrica, or are other GLP-1s approved? That's a great question. So liriglutide is the only GLP-1 agonist approved for weight loss in people without type 2 diabetes. The other GLP-1 agonists are approved for people with type 2 diabetes and just for their diabetes. So I just want to kind of show this one because this was one of the first medications to have different trials for both people with type 2 diabetes and people without type 2 diabetes. So the scale insulin trial was only people with type 2 diabetes. And what they showed was around 6.5% body weight loss compared to 1.5% with just diet and exercise alone. And the mean A1C went down 1.2%. Meanwhile, and then this was just kind of showing you what the insulin requirements for these people were. So at the beginning of using the medication, it went down, but eventually it went up to +3, whereas people with just lifestyle interventions without the help of medication went up to 18 units of insulin, more so than their mean daily insulin dose. So when they saw that weight loss effect, they did the scale trial, which excluded people with type 2 diabetes. So these are only people with obesity without diabetes. And there was an even greater weight loss effect. And when you look at liriglutide compared to placebo, for 5% weight loss, over 60% of the patients got there, and then 10%, a third of them got there. So what are the safety considerations of liriglutide? Mostly GI events, and then hypoglycemia if they're also on concurrent insulin use, or a sulfonylurea. And then there was a note about increased heart rate, but there were no increase in adverse cardiovascular events. So kind of going next to the other GLP-1 agonists, Semiglutide is not yet approved for weight loss, but there was a study in the New England Journal about its effect on NASH. So this, basically what I want to highlight here is, there was a 12.5% weight loss in the maximum dose group. And then there was also a pretty big primary endpoint of resolution of NASH with no worsening of liver fibrosis. So you know, as we know, we don't really have many treatments for NASH. It's really vitamin E, and then for people with diabetes, it's pioglitazone. And now we have some GLP-1 agonists, which is really cool. So just something to note. And there's an upcoming trial based on just for weight loss. And so far they've shown like 17% weight loss with this really high dose. Does liraglutide have the same effect on NASH? I haven't seen a study showing liraglutide having an effect on NASH, so I'm not actually sure about that. I only know about semaglutide. I think the thought is it's a class effect. She uses liraglutide, I think so. Thank you for that. And then the last FDA-approved medication is Orlastat. It blocks fat absorption, causes a ton of diarrhea. People don't really use this anymore. The efficacy is not great, and it causes a lot of people GI distress. So I'm just going to gloss over that. So which medication should you choose? You have options. It's not one size fit all. Try them out. Not all medications work for everyone, and there's a lot of side effects for all these medications, so be careful about that. Target dose of liraglutide for weight loss is almost twice as high as this. Yes, the dose of liraglutide for weight loss is very high. Insensible weight loss is still weight loss. Okay, so now I kind of want to get to a topic that I hadn't really been exposed to a lot in medical school, and I heard a really good Grand Rounds talk on it, and I thought I would share with all y'all kind of the data behind metabolic surgery. So we got a 52-year-old woman with diabetes, BMI of 39. She's been working with you on weight management. A well-balanced diet and liraglutide resulted in 10% weight loss, but she wants to learn more about bariatric surgery, which is least supported by the literature. Weight loss via medical treatment has been shown to be more efficacious in lowering hemoglobin A1C than metabolic surgery. Weight loss via surgery has been shown to decrease the risk of developing CAD. Undergoing bariatric surgery will extend life expectancy when compared to medical treatment. And weight loss via bariatric surgery is typically more sustained than weight loss via medical treatment. So which of these is not true?
We're still at about 60%, so I'll give people another 10 seconds to read and select.
Hannah, thanks for looking into that.
Yep, it should be launched. There's now 75% of people who have voted.
Yeah, so this was, it's the first one. So basically, metabolic surgery has been shown to improve all of this stuff, and we'll kind of go through the data. So the first thing I want to note is there's a change in culture now. It used to be called bariatric surgery, but there's a lot of stigma about that. What I like to reinforce with my patients is the surgery isn't just for weight loss, it's to change your metabolism. So who is recommended for metabolic surgery? There's a lot of organizations that say BMI greater than 35 and type 2 diabetes, or at risk of it, and all this other stuff. And these are the organizations that say that. You'll notice that the ADA is not on here. The ADA says BMI of greater than 40, regardless of level of glycemic control or complexity of glucose lowering regimens. So anyone with type 2 diabetes and a BMI greater than 40, they say you should consider metabolic surgery. So how much weight do people lose after going metabolic surgery? There's a lot of systematic reviews out there, and they kind of show you anywhere pretty wide ranges. And I didn't go through all the studies, but I did go through some of the more recent ones. And this one is from last year. And what it showed is there was a 30% weight change from baseline, and over 10 years, they basically maintained that weight loss compared to people with lifestyle interventions who got down to 10% down from baseline. But, you know, more than weight loss, will this help with their diabetes? And this is a lot of words saying, yes, that it will help. And I like pictures, so I'm going to show you some pictures. So in this systematic review, what they were looking at was how many people were no longer diabetic after metabolic surgery. And what they showed is large percentages of people after getting the surgery were no longer diabetic. Whereas in the control groups, basically no one became non-diabetic. And to kind of further this point, this was a study done last year, and they showed that the rates of recovery, meaning people who were no longer qualified as diabetic, meaning their hemoglobin A1C was less than 6.5 or 6%, depending on how they were classified. 72% of the people undergoing the bariatric surgery at 2 years, and over a third of them 10 years later, no longer had diabetes. And again, different study, same thing, 60 to 70% of people by 5 years no longer had diabetes, even though they had it before undergoing the surgery. So how is this occurring? There's two hypotheses that have been proven in rat models. We haven't proven in human models. But the hindgut hypothesis is saying that you're bypassing the proximal small bowel. So you get all your nutrients into the distal part of your bowel. So you increase hormones like GLP-1. And then the foregut exclusion hypothesis says that the duodenum and proximal jejunum just don't absorb anything. And so you don't tell your body that you need more insulin. So, you know, aside from like, you know, saying that there's remission in diabetes is great, but what are the long-term benefits of this surgery? So this was a retrospective study, I think it was in Sweden, of 15,000 patients, basically, 5,000 of whom underwent the surgery. And what they showed is 7 years after the surgery, the number of people in yellow underwent the surgery. People in blue did not. And these are all patients who are obese with type 2 diabetes. And the rates of macrovascular disease, which meant coronary artery disease, as well as stroke, all decrease. And all-cause mortality also increase. There have been studies, I don't have any data in this presentation about this, but there have been studies that there's been a decreased risk in basically all cancer when you undergo these metabolic surgeries. So I'm going to take a stop. Let's see. Is there a poll? Weird, I'm not seeing it. Sorry. That's wild. Wow. Okay. So what about life prolongation? So the Swedish obese subjects study, I kind of went over some of the results earlier, but they published a 20-year retrospective review in New England Journal, and they showed that people who underwent the surgery lived 3 years longer than people who just received normal, usual obesity care, but still 5.5 years shorter than in the general population. And in a Canadian population study, which was only 5 years, they still showed that the mortality rate was lower than of matched obese individuals. Granted, this is there have been new medical treatments in the care of people with diabetes that have not been taken into account, including the SGLT2 inhibitors and the GLP-1 agonists. So that's just something to take note of. And even now, there are a lot of studies about concurrent GLP-1 agonists after or not concurrent, I guess you would call it adjuvant liriglutide treatment after bariatric surgery. And it shows even better results than what we're seeing with this. And I want to stop there before I move on about metabolic surgery, because I think it's something that we don't really get taught about, or at least I did not get taught about. And I think it's something that has a profound effect on people and can really have a great effect on them. So if you have any questions, please ask. There is a lot of data that I did not include, and I just wanted to kind of highlight the highest yield, cool stuff. Is insurance cost usually a barrier? Does anyone know about this? Yeah. So I have this whole PowerPoint on people with Washington Medicaid of how to qualify for this. Basically, they have to follow the ADA guidelines, which is type 2 diabetes, BMI greater than 40. And then there's a bunch of documentation that you have to do, but it does get covered. Are there any additional barriers to patients on Medicaid? Oh, same thing. Yeah, so basically there is a way, but it is, I can send it to Courtney, the presentation on how to get patients with Medicaid to qualify. But yes, they can qualify, and it will be covered. So now I want to talk about a couple of things that we don't really recommend. Liposuction. It's got some weight loss benefits and waist circumference decrease, but has no benefit on type 2 diabetes. This was a study published in the New England Journal of Medicine about liposuction. And what they showed was people with liposuction, people without liposuction, people with diabetes with liposuction, people without diabetes with liposuction. Basically, nothing changed in their glucose levels. That's all you have to know about that. And here, this is the table kind of showing you what happened. And the only thing that changed was waist circumference. Everything else was not meaningful. So if someone really wants to decrease their waist size, liposuction does work. Dietary supplements. Most of these have not been well studied. There's a couple of like ephedrine, caffeine that have kind of been studied. Ephedrine does work in terms of weight loss. There's no long-term safety studies. So just be aware that it's associated with increased risk of psychiatric, autonomic, and GI symptoms, as well as heart palpitations. Can get replaced. Arita, I have not heard that, but I would not be surprised if subcutaneous fat could get replaced as visceral fat with liposuction. Do you have Derek asked, do you have information on some of the negative consequences of gastric bypass, pernicious anemia? Ooh. I do not. I'm sorry about that. Can you speak to the risk and challenges for patients of a surgical approach? I agree that it is a nuanced thing to counsel people on. I am not saying that everyone should go out and get metabolic surgery, but I do think that the data is very promising. There are definitely certain populations that I think would not benefit from a surgical approach. But sorry, there's a lot of comments now. Cody and I looked this up yesterday. 50% of patients after Roux-en-Y have significant iron deficiency. Steve says thiamine deficiency is a big risk. Yeah. Okay. So the ROS Weight Loss Clinic has nutrition classes and regular dietitian appointments for patients who have undergone metabolic surgery. There are several supplements that they can take at certain time points post-surgery. Yeah, I think these are all great points. One of the things that I think is tough is for patients who you think will really be on top of nutritional replacement and are really struggling to lose weight and are at really high risk of cardiovascular disease. I think that metabolic surgery is something to consider, but there are definitely patients that it might not be the best for, and it's something that you can have a conversation with them about. And there are a lot of great resources at the Weight Loss Center, and you can even just have people, like a lot of people, you know, I think one of my main goals with this talk was to address the stigma of metabolic surgery and to have people know that the data supports that metabolic surgery works and that it has a lot of great effects. All right. So, in summary, many common medications have a side effect of weight gain, so just be aware of that. And there's quite a few effective medications that can supplement lifestyle interventions. And bariatric surgery has a stigma. That's why there's a push to rename it metabolic surgery, but has been largely proven to be very beneficial in patients with diabetes and obesity. I'd like to again thank Dr. Montour. These are all the references. And this is a picture of my roommate's dog and this 8-week-old golden retriever puppy while I answer questions. Okay, so it sounds like a lot of the benefits may outweigh some of these side effects as long as they're addressed. I agree. Metabolic surgery is not a magic bullet. Rebecca's question, we've had some trouble at AMC with patients' insurances being accepted by the weight loss clinic. I have a patient with a marketplace plan that insanely does not cover any weight loss associated treatment. Wow. Huh. Did not. Yeah, I'm going to email Courtney this document about how to get Washington Medicaid to cover metabolic surgery. And then y'all can learn more about that and kind of update us if it still doesn't work.
Yeah, I'll upload it to the digital curriculum site along with Kelvin's slide deck too, so people can find it. It'll be up later today. Yeah. But yeah, the requirements are pretty stringent for patients on Medicaid. You know, very frequent monthly visits for weight checks, and they have to have, Kelvin's slide I'm sure includes everything, but we'll have to document a certain amount of weight loss before they're even considered for surgery. So I've had a couple of patients try it, and yeah, it's a lot of work.
Yeah, so the main thing I want people to get is there are effective ways for people to lose weight that are safe, as long as we are helping them along the way.
That was great, Kelvin. Can I make a quick comment?
Yeah, go for it.
I was going to start typing it out and it's taking too long. So I really liked the point that you made kind of in the middle of the presentation about for patients, like potentially really framing this as treatment for metabolic complications. And so I think it can be pretty crucial to not necessarily sort of use this as counseling patients on weight loss for the sake of weight loss. I think in large part because obviously people's sort of relationships with food in their body can be really complicated. And I think especially sort of in guiding people through the decision about whether or not surgery is right for them. Exactly as you said, it's not right for everybody. Of course, that's a very individual decision. But I think just like trying to be attuned to the sort of psychological complications that decision can have for people, sort of being I think the way that sort of weight stigma is carried out in our society and the way it can be internalized, that I think sometimes sort of undergoing a procedure to change your body can be something that just has a lot of nuance and complications for people. And so I think it's pretty crucial that we're just paying attention to all of that as well whenever we're counseling people.
Awesome. Well, thank you so much, Kelvin, for this talk. Thank you, everyone, for sort of sharing your insights. And with this, we will now pause, but also split apart. And interns, head to Mega Report. I'm going to throw the Zoom link in the chat, but it was in my email yesterday, and I think Johnny sent a separate email as well. And then for R2s and R3s, we'll take a 10-minute break and come back at 10:45 for Natalie's talk.